All right, everyone, we're going to go ahead and finish up the lecture with this last section for our last test in pediatrics. And I am a little sad that we don't get to be face-to-face for this, but otherwise we're going to go ahead and get going. So we're going to start out with adolescence and just doing what we usually do, looking at growth and development. And so one thing to keep in mind about adolescence is obviously this is time of major changes within the body, both female and male. This is when we start seeing puberty hit and the development that goes along with that. Females, you're going to see breast tissue start to form, and then you're also going to see the start of menstruation, and as well as different changes in hormones, hair growth in different areas, and same thing with males as well. One thing to keep in mind at this stage is also when we start to need to be looking at, again, what we focus on is health prevention and promotion, so we have to make sure that we're doing a good job of talking about that. And this will include talking about using contraceptives as, and I know we talked about it in the last class about sex ed in public schools and yay, nay, and what your beliefs on that are, but this is obviously time of experimentation, so we do have to make sure that as a nurse we're being, one, non-judgmental, and that we're offering just education. We're not giving them opinions. We're just answering questions as factually as we can. The other thing to keep in mind is when we do get an opportunity to have these this age group with us for whatever reason they come in to see us, we want to do the best we can in giving them the opportunity to have a one-on-one session with us without the parents in the room. And again, this is going to be based on if the parents are agreeable to that, but we do want to at least attempt to try and make that. So one thing I do want to just point out on the slide, there was a purpose to bringing up all that sex ed talk, is that the earlier use of contraceptives, and of course this is going to be female birth control pills that have some sort of hormone replacement in there, may actually decrease the height that females will grow to because of the increase in estrogen that causes our growth plates to close earlier on. Okay, so here is our pubertal development in males, and I do think you guys can go ahead and just take a look at that. One thing to keep in mind, and I think it is a little bit interesting when we start to again educate our patients as they come in, that males don't really attain their full height into 18, 20 years of age. And then also we have to make sure that we are increasing the supply of calcium, iron, and vitamins to keep up with their growth. We talked about it in our school age child, and now obviously it is as much of a concern in our adolescent about body image and perception and peer pressure. Very strong during this age group. So we do have to keep that in mind when we start talking to them about, again, healthy behaviors, because this is really a prime rate for what we consider high-risk behaviors. One point just on acne, we've covered this when we talked about skin, but just remember Accutane, not used as much, but you are going to see it, and this is a medication that is very tetragenic, so if you are going to start even a late school age, think 4th, 5th grader, all the way through our adolescent years, then we need to be talking about, again, our female patients, some sort of birth control. That conversation needs to be brought up because of how tetragenic that medication is. So again, review this, and can't do anything in our growth and development without looking at Erickson, and now we're getting into that identity versus role diffusion. And the one word that kind of jumps out on this slide, if you notice, is invincible. Again, this is where we get some risk-taking behaviors. It's not so much that this group of this population doesn't necessarily listen. They listen and they hear all of the talks about the dangers of underage drinking, unprotected sex, drinking, driving, drugs, all of that stuff, because this is where we're going to start seeing it showing up. And really, we're seeing it showing up at the school-age child as well. So all of these conversations need to be started at least the late stage of school-age child, but for sure in this adolescent growth. But they feel invincible. They just don't think it's going to happen to them. So it's not that they're not discounting that this stuff is happening. They just don't think it's going to happen to them. It doesn't factor into their environment. So this is also where they start to kind of figure out who they are outside of their family dynamic. So we see them branch out and start to say, hey, the great question, what am I going to be when I grow up? So all of you looked at it yourselves and said, I'm going to be a nurse, and that's why you're sitting here, and this is where that's starting. If, for any reason, if through these developmental stages, one isn't met, we see the opposite kind of start to come into play. So this is where we see their identity, where they do kind of figure out, this is my plan. And this doesn't mean it has to be a long-term plan until they retire. It's just confidence in the plan they create for themselves that makes them them, that doesn't have the parental factors or caregivers factors in, versus kind of this aimless attitude, not really sure where they fit into the bigger scheme of things. And this can cause a lot of stress. We are seeing much more issues in mental health starting at a younger age. So when we start talking about that, go back to our spring where we did our mental health depression. Eating disorders starts around this time. Any sort of body dysmorphia can start around this time. Again, it becomes a little bit of a control, and when they don't feel they have a firm control on things, then it can morph into poor coping mechanisms, or we can see this onset of mental illness. So keep in mind, isn't it? And I don't remember the stat exactly, but I do believe it's the first year of college, right around there, where you see the onset of schizophrenia. Because again, we're kind of going through this, it's a big transition where they break away from having this parental authority. Piaget, we have actual adult thinking going on here. This ability to problem solve and deductive reasoning is really important as well. They start seeing how they interact, and again, we look at how they interact in relationships. Impact in society is also going to be part of this more global view of themselves and that adult thinking. This is also where we're going to get into those catch-ups for the Tdap as well as our meningococcal vaccines. And also, again, we talked in the last class, but just a refresher, that human papillomavirus for females, they're also recommending it for males. Think kind of those last year of high school, right before you go into college vaccines, if for whatever reason anything needs to be caught back up. Okay, so we'll get right into a disease process, cystic fibrosis. I did send out the video, so I would highly recommend that you do watch those, just so that you have some sort of, especially if you're a visual learner, then you have a video to go back on and look at. But basically, it is an inherited gene, so we're looking at a genetic disorder, and it involves the exocrine glands. So the ones that we most normally think of when we think about cystic fibrosis, I would suspect, are the lungs, having a hard time with those secretions. Think about those, the percussion, chest that vibrates to help loosen up all that really, really thick secretions in the lungs. This is all related to the cystic fibrosis, but it also affects the pancreas, small intestines, and sweat glands. And that's a really important piece of the puzzle when we look at cystic fibrosis, because we have major nutritional issues. So your two major concerns for these patients are going to be respiratory, obviously, go back to our ABCs, and then nutrition. Now, people can become suspicious of cystic fibrosis all the way at the newborn stage when we start to see issues with meconium. Again, everything's very thick and tenacious. So our secretions are thick. The stool is thick because of the way this abnormality works. All right, and here it is again, tenacious secretions. They're in the lungs. Our coughing mechanism, remember, it's an important function. It helps us. It's our body uses that to help clear out our lungs for a normal person. What we get with cystic fibrosis is they will have this chronic cough because, again, our bodies are amazing and they keep trying to clear the airways, but it just is not effective and it doesn't work against all of this. It's kind of a losing battle, all this really thick mucus. And if you kind of like picture those lungs just kind of wrapped in kind of this slime, I'm totally picturing Slimer on Ghostbusters right now. So kind of just think about all that stuff hanging out inside those lungs. Obviously, our gas exchange is going to be poor. We can see atelectasis because this thick stuff is sitting there. And we know that anytime something sits, any fluid, anything like that sits in our body, it has a very increased risk for infection. So again, they're at high risk for pneumonia, atelectasis. We see the same type of symptoms that we do with like our COPD patients, which is really just, again, a chronic pulmonary obstructive disease. The barrel chest, chronic hypoxia that's causing clubbing, polycythemia. These should be some common terms that we actually talked about in our congenital heart diseases as well. So then again, we have the mucus in our digestive tract as well. So again, the pancreas isn't working as well for us. So keep that in mind. So our pancreas secretes all those wonderful enzymes that help break down that food that comes from the stomach. It all meets up in the small intestine. We absorb what we need. This process is not working as well in someone with cystic fibrosis. So here's just a nice visual. Go ahead and take a look at that if you want to, so you have an idea. Again, respiratory and GI. That's what we're looking at. And then the subsequent issues that come with the defect. So what we're looking at with someone that has cystic fibrosis, growth and development is obviously not going to be normal, quote unquote. We're going to see stunted growth, that malnutrition, they're just not thriving, possibly some anemia, and their stools are going to look different because we don't have this proper nutrition. They're going to be foul smelling, fatty, that steatorrhea that we look at. And unfortunately, and this is what I think you guys have all picked up at this point, the disease is it's not even a disease. The genetic disorder is cystic fibrosis that causes issue with the lungs, that causes issues with the digestive tract. And then we take care of the patient's response to that, or the secondary conditions. So as they have all these issues with nutrition, now we have to have support nutrition. And it goes all the way down into all these frequent stools, can even cause a prolapse rectum. So it creates a whole issue of problems secondarily that we're going to be having to make sure that we are aware of and including in our plan of care. So how are we diagnosing it? There's several different ways. The most definitive is the sweat chloride test. So definitively, the golden standard for the diagnosis of cystic fibrosis is that they're going to actually measure sweat chloride, and it's going to be greater than 60 milliequivalents. There are several other ways. A lot of times when this is picked up, though, is parents will notice almost like the salty taste when they give their kiddo a kiss. Think about just kind of a layer of sweat. That's a pleasant thought, but a layer of sweat that's dried on, and all that kind of extra salt. And that's what's showing up on these kiddos. So just kind of keep that in mind. But the gold standard is, of course, that sweat chloride test. So what are we going to do for them? Obviously, we're going to be assisting them with respiratory and digestional issues. We must keep the lungs clear of mucus and free of infection. And we do our very best. We educate the parents to also do everything that they can. But I'm sure possibly if you've worked in some sort of area in the hospital, CNA or something like that, flu and cold season, someone with cystic fibrosis, usually it's kind of a losing battle for them. They are going to get whatever's going around just because they're at such a compromised position anyway. We're also going to include chest physiotherapy. Again, think about that percussion, 2 to 4 times per day. Our kiddos, all the way up to adults, have vests that actually do that for them. So they may actually have to sit and wear this vest that is going to provide some percussion to the chest area and help loosen up that mucus and gunk. And the goal is that it loosens up to the point that that cough then is able to be productive. They're able to get that out. Different type of medications are going to go on board. They're going to work similar to the ways when we think about asthma a little bit. We want to create those airways. We want to get them as big as we absolutely can for a couple reasons. One, to bring the air in so we get increased gas exchange, because again, these poor people with cystic fibrosis have this kind of chronic hypoxia. Secondarily, though, we want those airways really opened up so it can expel these thick secretions. So keep that in mind. And then a mucolytic, which again helps kind of thin that mucus, decrease mucus secretions, which all in all is going to be helpful to the patient. All right. So, and then we get into this percussion. Sometimes they look at postural drainage, where it's a positioning of the client. And we want to make sure that we are treating any infection as they come. This isn't a wait and see type of condition for cystic fibrosis patients. We need to be sure that we are treating any sort of infection as it comes. They're also going to be put on synthetic pancreatic enzymes like pancreas or, I'm not going to pronounce this right, cotazyme. So, and maybe some of you might have given this in the hospital at some time or another, but that is going to be given to them orally. And anytime that we introduce anything into their GI tract, they're going to have to be given these pancreatic enzymes, again, to aid in breaking down that food. And then we need to make sure that we are also giving supplement of vitamins and making sure that they have the appropriate diet. Okay, so what are we going to be educating the kid about, and what are we going to be educating the parents about? Now, this can be diagnosed at very young, obviously right at newborn stage. So this is going to run the gamut of when the parent and caregiver are going to be the ones responsible, all the way into where they get into high school age. And now all of a sudden they're looking at a little bit more independence and they want to be taking care of themselves. And it's very, very hard for someone to be very different at that age. So just kind of keep that in mind. This has to be ongoing education. It doesn't just stop. We have to be including that child in the plan of care and allowing them more responsibility, but being sure that they're not putting themselves at risk by not following through. And this is so true in cystic fibrosis. I think about diabetes a lot too when I think about that. High school age is when they really stop taking care of themselves because they just get really sick and tired of being told what to do. So the same thing is going to be true about this, really any chronic illness. Okay, So client teaching specific for cystic fibrosis. Remember, we're having this change in chloride. So if a child's exposed to high temperatures or high activity, the child's going to have increased perspiration, increased salt loss. So we may have to make sure that they're increasing their salt intake, making sure immunizations are up to date. So the mortality rate of this, we are seeing that children are living to be 20 years of age and older, and this has really been a huge breakthrough. This, unfortunately, people that were diagnosed with cystic fibrosis or were born with cystic fibrosis, sorry, I keep referring to it as a disease, really had a very short lifespan. But the advent of better diagnostics, better education, better antibiotics, we're able to see that the length of life has increased. So 20 years of age is going to be about a standard, but that's not to say that you're not going to see that people live longer than that. And the number one cause of death in cystic fibrosis is going to be some sort of respiratory complication. All right. So testing can occur prenatally. Amniocentesis can actually diagnose this. And then people that have this, again, could have some sterility issues as well. Okay, so moving on to sickle cell anemia. Again, some great videos that I sent you, so please be watching those. So sickle cell anemia is kind of interesting because we get really hung up on that anemia part, but that isn't necessarily the biggest risk for these patients, and we'll get to that. But again, this is another genetic issue. So basically, something goes a little haywire, and it's most commonly found in African Americans. But the hemoglobin from hemoglobin F is supposed to change to hemoglobin A, but in sickle cell anemia, that hemoglobin also changes to hemoglobin S. So for our purposes, we have our hemoglobin F for our fetal circulation. As this baby matures and it transitions and starts to take care of its own process and creating its own blood cells, we now see these hemoglobin cells that are floating around in their hemoglobin A. They're perfectly shaped. They hold on oxygen just like we want them to. Sickle cell anemia, think of those really like crescent moon shaped cells. Those are our hemoglobin S. So we have some nice perfect hemoglobin A that can carry oxygen the way they're supposed to. But in sickle cell anemia, split the difference, you're going to have these crescent moon shaped cells that are floating around as well. And those crescent moons become, you should be in my head, the images that pop up. All of a sudden I'm thinking about the barrel of monkeys. Think of how those barrel of monkeys are shaped. That's exactly what's happening in your vessels. So with sickle cell anemia, they have these great hooks that grab onto each other and just grabs all sorts of monkeys and says, hey, come hang out with me. So now we have all of this clumping of these cells that should be flowing smoothly, easily throughout our body. Again, they're the ones carrying the oxygen to help oxygenate the cells. What happens instead is we get these big clumps. So now we have these big clumps of cells that are floating through the body. Makes the blood very thick. It causes obstructions. And that's where we really run into trouble with these clients, is these obstructions in the blood vessels. And then, of course, the fact that they have decreased oxygen carrying capacity because of the sickled cells. So again, it's kind of interesting. We hear this anemia, but what we're really worried about are the plugging of these vessels. And once we put a plug in there, anything past that plug is not going to get fed. So now we worry about ischemia and necrosis. It's the same concept in our MI. It's the same concept in our stroke. This is what's happening in sickle cell anemia. It's just that the plug looks different. So now it's these sickled cells that are creating the blockage of the nutrients and oxygen to the cells past it. The other issue is that these cells don't last as long. So a normal blood cell should last 120 days. These only last 16 to 20. That is a huge effort. That's a huge load to be put on the liver. So again, these clients can take on a little bit different color. And so you're going to see this jaundicey color. And then this is where we get a little more the anemia part into it, that we maybe traditionally think of anemia, lacking of those cells. So these clients have to be very careful that they don't put them into sickle cell crisis. So they can go about their daily business and again, be active, but they have to be very careful that they don't put themselves into situations that could possibly lead to a sickle cell crisis, which is just kind of a perfect environment for those sickle cells to really start getting pretty agitated and start clumping together. Dehydration. So let's go ahead and think about the pathophys of dehydration, and I hope that you're putting together, we are losing water, so these cells in the vascular space don't have as much water to float along with. So now what are they going to start doing? They're going to start bumping into each other. It's not, the nice river that you're sitting on your inner tube on, right? You're floating down the river. Now all of a sudden you're running out of water. So now these cells start grabbing onto each other. So dehydration is a cause of sickle cell crisis, infection, stress on the body. So fever, exposure to cold, hypoxia. Think of any sort of external or internal stress. We're going to see that they're at very increased risk for sickle cell crisis. When we go into crisis, we worry about increased ischemia, increased hypoxia, that we aren't supplying our major vessels, think brain and kidneys, with oxygen, and that we're seeing these places become occluded. This is especially true for the spleen. The spleen's kind of an interesting organ because, we can take it out. We can live without it, right? But on the other hand, it does a really good thing. It's almost like a little reservoir of blood for us. But in sickle cell patients, it becomes a little bit of a detriment because we're going to see occluding there. And so you will talk to people with sickle cell anemia that more than likely have had a splenectomy. All right, so again, we're looking at occlusion. Think that occlusion, that's what we want to be thinking of. Blockages in those vessels. And up to 85% of effectives survive to age 20. Again, the lifespan, because of all this damage that is happening, up to age 20. So basically, again, it's a genetic disorder, but it's usually not diagnosed until some sort of stress. So if they have some sort of infection or respiratory issue, or they become very dehydrated, some precipitating factor causes this crisis, and now we have these symptoms and signs and symptoms, which leads to further testing. So this hemoglobin electrophoresis is what's going to be able to detect if those cells, if they're hemoglobin S versus hemoglobin A. So what are we going to do for these kiddos? The issue, and again, think when we have an MI, we have angina, right? We have chest pain that is telling us that there's a blockage. Whenever we have a blockage of blood to a tissue or an area, we have pain. That's our body's way of getting us to respond and say, hey, you need to pay attention. I'm not getting fed. And that is same concept applies to sickle cell anemia and sickle cell crisis, where they are going to have immense pain from all of these blockages that are occurring at smaller levels throughout the body. So they're going to have pain from hypoxia at this tissue cellular level, possibly going to have issues with the spleen, which again could lead to a splenectomy. Growth and development is going to occur, possibly see some decreased fertility. Think about our arterial insufficiencies. Remember that from 102? Think about all those different issues that we had, and leg ulcers. We're going to see that as well here. So if we know that these issues is what's going to cause some higher risk for stress and sickle cell crisis, then we want to include interventions that are going to help prevent that. They need to be educated to stay hydrated. They need to make sure that they are well rested, proper nutrition. We absolutely do not give them aspirin, which we already know we hate aspirin in our pediatric patients. Hate is such a strong word, isn't it? Let's just say we don't give aspirin unless otherwise indicated for special conditions by a doctor. That sounds so much better than hate. But they absolutely will not be getting aspirin. No cold packs because it can increase sickling and vasoconstriction. And again, if we're having these clumping or bigger cells stuck together that need to get through these vessels, then we absolutely don't want to do anything that's going to vasoconstrict. And then promptly treating or coping with any secondary stress. So we want to make sure that we are educating and we are doing a good assessment so that we can kind of figure out what are these triggers, because each patient is at risk for all of these, but some you're going to see come in with kind of the same issues over and over again. They kind of have the same triggers. And this can be diagnosed through amniocentesis. Hemophilia. So there we have what we kind of refer to as a bleeding disorder. So we have to remember, again, another genetic disorder. That's what we're looking at here. So we have a deficient factor 8, and then we can also have a factor 9 that is part of this clotting cascade. So it's not that they can't clot, it's that it takes so much time for them to clot. And I also sent a really great video that I think has really good visuals about how this deficient factor 8 can or affects that bleeding time. So our PT is normal. Remember, we have a couple clotting cascades, all the way back to that pathophys. But we're going to see an increased bleeding time and increased PTT. And then, obviously, the severity of this is going to depend on how much they have. And remember, this is a genetic disorder. So what's really interesting is that it is carried on, it's an X-linked disorder. So women are carriers, but so they, okay, I got to walk myself through our XXXY. So women are carriers, but they can pass the bad, I'm using quotes here, the bad carrier X to their male who has an XY. I think I said that right. Feel free to email me if I told you totally wrong. So females have two X's, so we're able to, if we have a bad X, our good X is going to take over and give us the clotting factor that we need. And male, if they get the bad X with the good Y, they don't have a second X to overcome this. I may have totally confused you, but feel free to email me if I have. Otherwise, watch that video. It does a really good job of explaining that. Okay, so we can go ahead and do some DNA testing, and I just have to tell you, genetics and these disease processes that we're looking at, this is your future. I know I've said it before. I actually just talked with someone who said that if we're ever given the opportunity to go visit the genetic testing area at Avera, we absolutely should. So I would recommend anyone who's over there for practicum, talk with your preceptor and see if you can get a little sneak peek at that, because it is just so huge. It is truly the future of healthcare is this genetic testing. All right. So, okay. So what's happening here? We think bleeding disorder, bleeding out, dying from loss of blood. That isn't exactly what happens with hemophilia. Again, it's that it takes so long for that clot to form over whatever injury they have that they have this prolonged bleeding at the site. Now, what becomes interesting is, and we don't even realize all this clotting that's taking place. We picture a scab on our arm that we can visibly see, but there's always these little micro bleeds that are occurring as things move, and again, our body adjusts. And so what we can see, and also any minor trauma. So what to us, we bump into something, we may get a bruise. To them, they're going to have extreme bruising from touch. What becomes their biggest issue is the bleeding into the joints. So again, it's not blood loss, it's just that blood is going into areas that we shouldn't be getting blood. And what we call this blood in the joints is hemarthrosis, and you're going to see these large deformed joints. Very painful. So we are going to be making sure that our plan of care includes some sort of pain control. And simple as rice. Remember rice? Rest, ice, compression, elevate. That's what we're going to absolutely be doing. But remember, it doesn't take much for this prolonged bleeding to occur. Secondarily, we're going to actually treat them. We're going to give them the factor that they're missing. We can also include fresh frozen plasma and possibly blood transfusions if we need to. But the best choice is the factor 8 because, again, that's what's lacking. So we can just go ahead and fix it with the one thing that they're missing. All right. No surprise, we're going to avoid anything that could increase or prolong bleeding, which includes aspirin, codeine, and NSAIDs. Make sure that we apply pressure longer than we would for, think IVs, lab draws, 30 seconds to a minute, we're putting pressure on there. Here we're going to put up to 5 minutes. We're going to be looking for any sort of blood in their urine or stool, bleeding gums, and obviously we're going to be doing a good physical assessment and looking at any sort of joint malformation. Contact sports, not going to be able to go out for contact sports. And then another thing is what we're going to have to really be paying attention to the spleen. So death can occur from an internal bleed that isn't stopped in time. Now, for these patients, if they have some sort of traumatic injury, we want to make sure they're getting factor 8 is what they need to be getting in order to help stop the internal bleeding where we can't put pressure, obviously. And again, it's not going to be like visible blood loss. We're just going to be seeing that they have this. And then again, think signs and symptoms. If we're having massive hemorrhage, even if it's internal, we're going to see changes in our vital signs, tachycardia, hypotension, increased respers, that type of thing.